Please stand up. Who of you has an elevated PSA? Please stand up and shout your name. Then I can take a biopsy. I hear nobody. Why not you standing up? If your PSA is elevated, a urologist will use 12 needles with transrectal ultrasound biopsy, which is a blind biopsy. Are you still feeling comfortable? 1 out of 2 of you, men, will have a biopsy with these needles. Can I have the first images? If they're there, please tell me. I fight imaging cancer using MRI. 1 image tells more than 1,000 words. Look at those 2. Cancer. A very powerful image. Lost your way? Use MR imaging to navigate. Take off the blindfold. Use MRI. That's the message. No blind biopsies anymore. We want to help patients by using imaging. We want to cure them. We want to reduce side effects. This is our team, Prostate MR Reference Center. So I'm going to talk to you today with prostate cancer. Decrease mortality. Prevent this, what's happening. Isn't it terrible? Dear gentlemen, we want to reduce the side effects of surgery. How bad is it when you are impotent? Or how bad is it when you're incontinent? If I would be incontinent, I would not drink coffee before my presentation. I would wear a dark pant, a diaper, and my presentation would be over in 10 minutes. Otherwise, I would pee in my pants. Uncertainty. This guy doesn't know what to do. Take pills, have your prostate removed, radiotherapy, or drink a glass of water, active surveillance. It's in the blind. With MR imaging, we can make the difference, and I will show you. Prostate cancer, why care? Dear ladies, 1 out of 7 of you will get breast cancer. However, 1 out of 6 men are getting prostate cancer. Now please, gentlemen, all of you sitting on that side, gentlemen, please stand up. Please stand up, it's just an exercise. Stretch your legs, please stand up. The ladies may sit down. Yeah, you're too young, but please stand up. This is the number of men in this audience who will get prostate cancer. Please sit down. It's not personally, but it's the number of men. You have your mammogram, or your mother, or your grandmother, every year. But dear sir, where is our mammogram? That's bad, isn't it? She gets imaged, and not you. Discrimination, sexual discrimination. Prostate cancer, 1 out of 6 men. Well, we are about the age that it may approach, don't we? You're younger than I am, but okay, we are getting nervous. And I talked to your CEO, Bernd Onerzorger, and he is young, but he said, Jelle, I'm already a little bit concerned. Mortality of breast cancer is going down. Why? Because you have your mammogram. And we don't have a mammogram. So if we wait a little, more men will die from prostate cancer than women from breast cancer. So we should do something. What happened in the millennium? Imaging. So gentlemen, we need to do imaging. MRI. 1 MRI a day keeps the urologist away. I would like to present to you John. John has a PSA which is elevated. And John goes to the urologist. And the urologist sticks in his finger. Digital rectal examination. But the finger of the urologist doesn't have eyes, and we have MRIs. So, now beside that, he's sticking in needles. There's the prostate. It's just below the bladder. A low part here. All the needles, those needles, blindly done, miss the tumor. Now, this is MR-guided biopsy. Yes, the target has been hit. This is reality, which I will show you in the next 15 minutes. Prostate cancer. If your PSA is elevated, if you don't do anything, you get 12 needles and the finger. Both is bad. Now, let's assume that of 10 men, the PSA is elevated. Okay, 8 of you don't have cancer. You get your 12 needles and you go home happily. Or you have sepsis, then you don't go home happily. Okay, sepsis is fever after biopsy. 2 of you have cancer. 1 of you has a insignificant cancer, and the other one has a significant cancer. What does it mean? Cancer is like a cat, but this is a kitten. This insignificant cancer won't crawl you. No, it's a nice kitten, isn't it? You like cats? If not, you like cats, nice cat, isn't it? You have insignificant cancer, but if you go to the urologist and you say, okay, what have I got? Insignificant cancer. What word do you remember? Cancer. So you look at your prostate, say, hey, prostate, you got an insignificant cancer, but okay, when is that cancer going to be significant? Let's separate. And before you know, your prostate is gone and your potency. Now, if you have a significant cancer, that's the cancer who's going to kill you. We want to find the significant cancers. We don't want to find insignificant ones. This is already an intermediate aggressive cancer. Not that bad, because the cheetah is afraid of humans, but he has already 2 metastases. And of course, if you have something like this, remove it. Significant cancer. So we want to detect the significant cancers. This is the 40-40-40 rule of trust biopsy. These needles, blindly shot. In the upper right, you see a needle which is hitting an insignificant cancer, just by chance. You don't want to know that. In the middle, you see that this needle is missing the cancer. And in the other image, you see that it hits not the most aggressive part. So there's undergrading of the aggression. That means wrong therapy. Okay, can we do something about this? Yes, we can. We can do it with MRI. T2 weighted imaging, diffusion weighted imaging, and dynamic contrast MR. T2 shows anatomy. A dark area, especially when there is a red arrow on the image, is bad. So this is something. But it can also be hematoma, fibrosis, prostatitis. For this, we need diffusion. It shows the motion of water molecules, and when there is a high cell density on the ADC map, diffusion is restricted, it gets black. Whereas in non-significant cancer, it remains white. That's nice, good. There is a correlation between the darkness and aggression of cancer. The darker it gets, the worse it is. You can see this on an image. There is no significant cancer over here, low grade. You hardly see it. However, when there is a black hole in the universe, it's a bad guy. You need to treat this cancer. So, MRI is nice. Also, we have contrast-enhanced imaging, which shows you hypervascular structures. Also, inflammation and benign prostatic hyperplasia. So this is a very sensitive tool, but unspecific. Therefore, we need to merge everything again together, and we need to do multi-parametric MRI. This is a 65-year-old patient, PSA is 9, and the urologist just shot some needle, and he found an insignificant cancer. So, okay, now, that's good. So you can do active surveillance. With insignificant cancer, you can watch and wait, and, well, if you're up to it, you can do nothing and just have a needle every year. 12 needles, I mean. Okay, now, however, this man had an MRI, and on the MR, you see on the T2 weighted image, at the anterior part, something wrong. And on the diffusion weighted image, over there, you see a black hole. And you see in the red circle the insignificant cancer. This man has a significant cancer anteriorly in the prostate, completely missed by 12 needles. Can we hit it with one needle? Yes, we can. Most certainly. We can hit it with one needle. This is what we do, MR targeted biopsy. Takes only half an hour. Here's the lesion, this is the needle, and there's the Gleason grade, intermediate cancer. And the patient can go to the appropriate therapy after many, many, many wrong needles. Now, urologists always say, yeah, MR is good, but if it's negative, the patient shouldn't go home, we should use our needles. Now, when my MR is negative, I go home. No needles for me. Literature supports it. The negative predictive value is 95 to 97%, which is very good. This is a study which I would like to show to you in Australia, the Dutch-Australian study. We had 223 patients with an elevated PSA. Nothing more than elevated PSA. They all had an MRI. When the MR was negative, no biopsy. When the MR was positive, MR targeted biopsy. And after that, as a surprise, they all got the 12 needles, just for this trial's sake. So now we can compare the blind biopsy of urology versus the MR-guided biopsy. What's happening with all those patients? Primary outcome. In more than half of the patients, MR was negative, with a negative predictive value of 97%. So, when your MR is negative and your PSA is elevated, go home, be happy. Don't go to a urologist. The reduction of overdiagnosis of your insignificant cancer was more than 90%. So let's assume you get the needles of the urologist, 12, and you got one needle of me, the MRI. Then the chance that I detect an insignificant cancer, so the kitten, which will not kill you and which should not be treated, is 20, and with you it's only 2%. So there is a significant difference. And also, because we do targeted biopsy, we're finding in 12.6% more cancers. And the number of cores is going down. Reduction of almost 90%. So only 1 or 2 needles, or perhaps 3, instead of all of those. What do you like more? Cheaper healthcare, that's what I like more. So what about cost? MR is expensive, isn't it? The machines and the things you make are enormously expensive. Millions of euros. Bullshit. If you do a cost-effectiveness study, and if you look at the cost at the y-axis and the effectiveness at the x-axis, you want to be in the left segment. You want to be in the green area. Now, we did a Markov modeling, put in all the data, and what we found, that in the Netherlands, in even the United States and Australia, this technique is cost-effective. MR expensive? Bullshit. Scientific proof, the Roy European Urology. What about the interpretation of the radiologist? I'm coming to that later. If you do it standardized, you can see that the agreement of insignificant versus significant cancer between the two readers is 95%. I'll tell you a secret. One reader was a urologist. I trained him for 2 years and he was better. Just a little bit, not significantly. So you can learn this technique standardized to urologists in Brisbane. This was presented at the Body CT and MR meeting last week in New Orleans. And this young guy, the youngest guy ever, with this presentation, got the Lauterbur Award, a very prestigious award in the United States. So he was better than all those guys from Yale, Stanford, etc., etc. The guy from Nijmegen, he won the prize, thanks to MRI. What about lymph nodes? Can we detect small lymph nodes? Just a few words on lymph nodes. Well, one nice thing, the iron oxide particles are back. We produce it, we make it, we give it to patients. What are those tiny iron oxide particles called Cinerama Combidex doing? You inject it into the patient, and you see he likes it. I tell him all kinds of stories. The black stuff is going into his body, And in 24 hours, his normal lymph nodes are black. That's good. Now let's imagine you have a chandelier with 100 light bulbs. One of them is cancer. And I'm a treating physician. What should I do to put off that one diseased node? Take a cannon and shoot the chandelier from the ceiling. You can imagine what will happen to the patient. That's what you do with radiation therapy. It's terrible. Now, it's better to just push a button. All the lymph nodes which are normal are black, they go extinct, and the abnormal remains white. Now, this is what happened on the image. Is there a radiologist in the audience? I'm the only one. Wow. Okay. Now, which one is the lymph node? You get a beer if you have it right. If you have it wrong, I get a beer. Probably I get drunk completely tonight. Okay, now, poof. Positive lymph node, always look at the circle. And the black one at the top is normal. So this is the diseased lymph nodes. It's so simple. Fantastic. This is MR imaging. Now we can do tricks. We can make them red and green. And we can now, whoop, back. I hope I can get the video moving. We can merge it to CT. This is CT MRI fusion. And now, this is an image. And at the circle, you see tiny small lymph nodes. And what's the clinical relevance? We can do intensity modulated radiotherapy targeting. Only hit the diseased lymph nodes and cure this patient. We go from a grape to a rice grain, from 8 to 2 millimeters. Fantastic. Of course, we need to have the fantastic coil technology to have the highest resolution possible. Because with 7 Tesla, we can go to 1 millimeter. That's what we've shown already. And with your 60-channel coil, we even may go better. Unbelievable. Science fiction. What are the obstacles? Okay. Obstacle number 1. Urologist. Do they believe us when we show a movie like this? This is called Der Wasserrutsche. Don't need a translation. Hoppa! This, by the way, was not me, it was a stand-in. Urologists believe it. They believe that MR can do it. Even Axel Heidenreich, whom I met at Bonn 2 weeks ago, said, Jelle, MR is getting there. Okay. So the urologists are getting there. Now, the volcano is erupting. This is a warning for radiologists. Don't let this happen to you, Pompeii. Okay, they hear the rumble. They see the smoke. They don't do anything. We have to wake them up. They should go away. They should do something. This is the number of prostate MRs in our institution in the past 8 years. And in the Wesley Medical Hospital in Brisbane, Australia, they do more than 5,000 prostates every year. That's why they have ordered 2 new Skyras. And that's probably why the sales in Australia, there was an award today. Where's the Australian man? Is he still there? That is why your sales are improving. Thank you very much, Mr. Prostate. You only see what you look for. You only recognize what you know. If you look for a nice lady, you don't see it. If you look for a coyote, you see a coyote. Wow. So we need to teach the radiologist what they look for. Radiologists are unaware incompetent. Oof. When I say this at meetings, they almost shoot me. And I would like them to make aware incompetent and finally aware competent. By the way, this is also true for pathology and the finger of the urologist. That's life. Is this the young lady or the old lady? Same image. Interpretation. Resonantia magnetica, the other things I cannot pronounce, these are all the same words for MRI. And we need to talk one language. That's English. In prostate it's called PIRATS, interpretation in one common language. Okay, it shows on a 5-point scale the probability of a significant cancer. That's good. And it's getting there. Radiologists, step by step, are learning it. What about imaging? An acquisition protocol should be fast, good, and cheap. Okay. Teach, teach, teach. In 2 days, I will be in Baltimore for the American Rental Race Society Prostate MR course. I'm teaching. I was in Australia. I will be in Scottsdale. I'm also in Nijmegen. We have to teach our radiologists, but also our urologists. They need to understand the images. We do have the minimal requirements written down, like traffic rules. But we need to have schools to drive. We need to have a certificate. We need to have quality control. When you are reading a wrong MRI as a radiologist, you should not get reimbursed. In England, it's happening. So we are getting there. We should give tickets. I think double reading should be done in prostate. If you can read it very simple. If you have the interpretation tools, computer-aided diagnosis, it is so damn simple. It's just copy-paste from what I learned from breast imaging. Thank you very much, ladies. We need to build a prostate MR network. This is also copy-paste from what Jan Hendricks, the radiologist with mammography in my hospital, learned me 20 years ago. We need to have a reference center, teaching center, quality center, and around that we have to have centers of excellence which then will learn the technique to others. We need to communicate through internet, have readings through internet. It's so simple. Why don't we do it? I got this guy, Les Thompson, at my TED Talk in 3D at the stage, just from Australia. This is the starting global network. And you can see by the dots that prostate MR in Australia is booming. This is only the beginning. I've shown already that it reduces cost. The iron oxide particles reduces per patient more than 1,500 euros. That's good. The future, a few words, and then I'm done. Screening on prostate cancer. Oops, if you say that in Europe or in the US, you're being shot by the thrust needle. It is bad. Why? Because the benefits, mortality reduction, that's what you like. Less metastatic disease, that's what you like even better, are much less compared to the negative things. The negative things of TRUS ultrasound, PSA screening is too many biopsies, all those needles, and in 40% unnecessary overtreatment. This is why, both in Europe and in the United States, prostate screening is not being done, despite the benefits. Now, MRI, as I showed, and has been shown by many others, will show the right treatment in aggressive cancer, lowers the cost, reduces the needles, and reduces the overdiagnosis and overtreatment. So, if you do PSA and MRI, you are there. One but, it needs to be cheap. So you need to do at least 5 MRIs an hour. This is doable. A non-invasive test without contrast. Yes, you can do it. 5 patients per hour, 1 high resolution T2, and a diffusion in the axial plane, and that's it, with a perfect coil. I think the solution is almost there. Also, we need standardization of reporting and communication, so that we can read each other's MRIs, double reading, that we can learn from each other, that we form one global prostate MR network. That is my dream. And I know that my dream comes true. In 5 years, we will start with screening in the Netherlands. And in 8 years, I will have Combidex globally approved. And I always keep a promise. Thank you very much for your attention.